Okay, I will start this case by just not giving you the history or the presentation. So here's the radiograph from February of 2019. And looking at the radiograph, and I have a CT just from the next 2 days later, so this is the 18th, we see multifocal, nodular, otherwise ill-defined subsegmental sized opacities in the lungs. Yes, this turns out to be lymph node enlargement. So let's go to the lung. And I'll make this big. Give you a feel for what these focal opacities look like. There's one there with the small airway traversing it. More of the same, some ill-defined ground glass attenuating opacities, but multifocal, multilobar. Larger one in the periphery of the lung, but again, ill-defined margins with adjacent lung. And here is another one that's relatively large, that on this thick cut probably has small airways that are patent within. And here is the lymph node enlargement. So based on these imaging findings, at least initially back then, a diagnosis of sarcoidosis was suggested. So now let's go forward in time to January of this year. Lung window will show kind of a waxing and waning phenomenon in the absence, as best I can tell, of particular treatment. So there are opacities that have developed in some regions that are new, others have resolved. But again, we still have ill-defined subsegmental sized nodular and some larger opacities, again, in some locations containing patent bronchi. And certainly with respect to sarcoidosis, I don't associate these kinds of opacities, say here, with air bronchograms as typical of sarcoid. One can get focal opacities, maybe a sarcoid galaxy sign, but these opacities, by virtue of their shape and varying size, not really suggestive of sarcoidosis in my view. And the lymph node enlargement appears to have diminished from then. So here the history is really interesting. So let me bring up the context. So at some point in time, he presented with thrombocytopenia, then was discovered to have Coombs positive autoimmune hemolytic anemia. So by virtue of those two findings, a diagnosis of Evans syndrome was made. But then it turned out that he had, someone discovered a history of infections. I think sinuses was one, I can't remember the other, and some low IgG involving at least some classes. So given this and this, or both, but particularly this, the possibility of an immunodeficiency state of some kind, I think these findings are very consistent with GLILD. So one can have lymph node enlargement and these kinds of opacities with this kind of morphology and a spontaneous waxing and waning phenomenon over time is very consistent with GLILD. So I don't know if he actually has CVID. Of course, one would think so if he has hypogammaglobulinemia. But certainly this has been described in the context of many immunodeficiency states, and this is just a partial list of immunodeficiency states, which themselves may be associated at some point with Evans syndrome, and certainly as well as the George syndrome, for example. So I think it's very likely that he has some kind of immunodeficiency state, and this represents GLILD, not sarcoidosis.
Does he have a big spleen, Howard?
Oh yeah, let's have a look. It's a good question, because I had a patient the other day with a spleen that was big, and let's see if it was this person. So that looks a bit generous.
It's a build, yeah.
Yeah,
I
let's
find
have a
that
look
can be
at
very helpful. I don't know. I think it's more often than I'd say probably almost every case I've seen of GLILD has a big spleen, but
maybe it's a bit big.
it looks a little juicy.
Yeah. Yeah. But does everyone agree that these kinds of opacities would be unusual for sarcoidosis, particularly things like this? I certainly think of lymphoproliferative disorders
Yeah.
in the appropriate context when I see that kind of thing.
Yeah, you mentioned the air bronchogram. I find that helpful too. That makes me. I first thought when I started showing the case, this might be a lymphoma case, just because of the nice air bronchograms.
Yeah.
So Howard, there was no biopsy of the lung lesions, right?
No, we do not have a biopsy. So right now it's a strong presumptive diagnosis of GLILD.
And
I think they're going to get a more formal immunoconsult again.
Okay.
And if they make that diagnosis, particularly of persistent hypogammaglobulinemia, then I think the usual therapy involves IVIG. And so I think it's going to be sorry, go ahead.
IgG4 disease is not on your list, right?
I certainly think for the pulmonary findings themselves, if I saw opacities like this in the lungs, and even in the absence of lymph node enlargement that were otherwise unexplained, and I was thinking lymphoproliferative disorder, then certainly depending on whether other systems are involved, IgG4 related sclerosing disease could definitely produce opacities like that, right? Yeah.
Okay.
Yeah, something like that, for example, in the differential diagnosis would be IgG4 related sclerosing disease for those pulmonary findings. So that's a strong presumptive diagnosis, I think. This is interesting. So this history goes back quite a ways, which I'll show you in a moment. This is a radiograph from May of 2018 in this young person, and he has pleural fluid. And I'm sure that was probably tapped, but a diagnosis was not made at that time. I'm not sure what happened between then and the next imaging that I have is from February of 2019 that shows he has, and I'll show you the chest in a moment, both pleural disease, pleural fluid with enhancing and or slightly thickened pleural membranes, but also peritoneal fluid. And everything looks okay otherwise. So just looking at the abdomen, peritoneal fluid, the other organs seem to be fine. So peritoneal and pleural fluid. And I wondered, let me just go to the chest from February, if I can get there as well, of 2019. He's got a multinodular goiter, which is not related. I'm curious. But I was trying to discern, and I'm not really sure whether in addition to just pleural fluid, he's even got some pleural membrane thickening. If so, it's mild up here and maybe here. But he had a workup, and based on his history, and I'll bring this up alongside, which started, so something happened to my, something happened to my conversion, so nothing pasted there. So basically, he had a history of, he's from Kenya. He went back to Kenya apparently in 2017 sometime. And then he came back obviously with the pleural fluid in 2018. And that was tapped, no diagnosis was made. And he went to different hospitals. They did more biopsies, nothing happened until last year, in which case he had a pleural fluid removal, I think a pleural biopsy as well, that eventually grew tuberculosis. So it wasn't apparent immediately, but with that history, they actually started treatment before his cultures were positive because there was such a high pre-test probability of tuberculosis given that history and the travel history that they started him on TB therapy. But eventually the cultures were positive. So a case of pleural and peritoneal tuberculosis. No lung disease that I can see. So we see that once in a big while.
Mhm.
The history is really important, which somehow didn't make it so. Sorry about that.
Yeah,
Okay, those are my two, Jeff.
yeah, and I think Travis showed a case of peritoneal TB looking like carcinomatosis. So yeah, we've
Yeah.
seen.
And the recent
Okay.
follow-up shows that he's looking okay. This is the recent follow-up, and he's doing fine. Yeah.
All right. Well, thank you, Howard.
Okay.
Okay. Who
I
would
can
like?
go.
Oh, is that you, Seth?
Yeah.
All right.
Let's see here. I don't remember what these cases are. Oh, yeah. This is something I've never seen before, which was fascinating to me. You can see quite an expanded thorax, scoliosis. Hard to make out what's going on here in terms of paramediastinal stuff. I'll show another radiograph. Small kind of pleural fusion on the right. We show a radiograph that was taken a little bit after, where you can see these lesions that are actually, if you, hard to tell where they are here, but on the lateral, I think we can localize them to the posterior mediastinum. So this is a patient who, I'll show you the chest CT, has Marfan's, and I was just showing this case a couple of minutes ago. It's pretty fascinating. So you can see the patient's had a dissection, has dural ectasia, which is actually more common than I thought. I always associated dural ectasia with NF, but I guess dural ectasia is also quite common in Marfan, actually considered part of the criteria. I didn't even check the lungs to see if there are any real findings. But what was fascinating about this case, let me make sure I have the right one because I don't want to waste people's time. It's the other one. So let's see, this might be a little bit to load, hopefully not too painful. Well, that didn't work well. Anyways, so you can see that there are these areas of dural ectasia, but darn it, I loaded the wrong one. Sorry. I'll just go to the, yeah. Too many images right here. And basically this patient developed this recurrent right-sided fusion, and they tested this and they kept getting CSF fluid out of the right-sided effusion. And it turns out one of these areas of dural ectasia somehow communicated and fistulized with the pleural space. So this patient actually, and the patient also, according to the person who showed me this, developed severe headaches and other neurologic symptoms related to CSF pressure, depending on how, when she sat up or stood up very quickly, and depending how the patient was positioned. And this was fixed, I guess, through some sort of surgical method. But this was a, let's see, coronal lava. So this was a fistula between an area of dural ectasia and the pleural space, which, again, I had not seen before. I don't know if anyone else has seen that.
Wow. No.
I've seen that as in the context of spinal fusion surgery, in which a connection between the CSF space and the pleural space was established during surgery.
There are some really nice images here. I just can't, there's so many on thousands of images, and I honestly didn't look through them all. But yeah, there was some direct communication between one of these areas of dural ectasia with the CSF, and the patient was very symptomatic, and they went ahead and fixed those. So I thought that was quite fascinating.
So
Do you
it's
think
a
it's possible?
subarachnoid pleural fistula. That's what I'm looking at, some case reports here.
Yeah, I guess that's right. Technically, is it a, yeah, I guess if it's a dural ectasia, is it technically the subarachnoid space? I guess. I mean, geez, I would imagine.
Yeah.
But
well, those are more than dural ectasia. Those are actually kind of lateral meningoceles fluid
Well, right.
upset.
So we were debating, right? At what point does dural ectasia become a meningocele, and is there a difference between a lateral thoracic meningocele like you see with NF and just simple dural ectasia? Are they the same? Is it just at some point dural ectasia becomes a meningocele? I'm glad you brought that
I
up because
think
we were
that,
debating about it. Like, is it a meningocele? Is it dural ectasia? At what point does one become the other?
no, you can have dural ectasia without a meningocele. So, for example, as you mentioned, one of the criteria for the diagnosis of Marfan's is dural ectasia involving the lower lumbar
Right.
spine and upper sacrum. So, for example, you might see that just by virtue of perceiving an enlarged spinal canal in terms of its dimensions, without having to have an
true
actual
meningocele. Because, we were saying we would call these little things up here like little areas of dural ectasia, but once it starts kind of getting out past the neural foramina, they become meningoceles. But that was just I don't know if that's correct or not.
Could they have put a needle into that in trying to do a thoracentesis? Did I get you correct that they may have done a thoracentesis?
Yeah, they did a thoracentesis because
they went paraspinal and put a needle in that by inadvertently.
I don't know.
Yeah, okay.
I'm not sure, but maybe. But I think the patient presented with a pleural effusion before there had been any other procedure.
Oh.
So I don't think that's what I'm saying. I don't think it was iatrogenic because the patient just presented with a large effusion, and which I don't have imaging of, but we have a history of, and then they drained it and got basically CSF fluid out, and then we're kind of dumbfounded. And then the patient presented again when this study was with again another, this time kind of smallish pleural effusion, which again was drained and was CSF, and then they went in and did surgery to whatever close up the hole. This is just, I showed this case I know a few weeks ago, but I have now another study which I really think is quite interesting. I'll just load all three of these. Nope. I'll just start one at a time. So I showed this a few weeks ago of a woman who just presented with, we talked about IMHs and probably that there isn't really a vasovasorum rupture, and you wonder maybe there's some areas of whether these are developing intramural blood pools or actually areas of intimal injury. Nonetheless, I showed this and it progressed to this, but we also have we talked about these intramural blood pools here. We talked about this, but then she got another study, which I'll pull up side by side. And, I just had not seen a case where we had basically 3 studies showing how these things evolved, how usually when you see these little basically pseudoaneurysms of the intercostal arteries, like we do with these intramural blood pools, they do heal. And so here was a subsequent study just about a week later, showing that some of them are still there, like this one, but the other one that, I don't know why these aren't linking, guys, I'm sorry. But you can see other ones had resolved, and additionally, a lot of the ones along the descending thoracic aorta, and you can see that we can better see the bronchial arteries actually connecting with the true lumen of the aorta, whereas before you just saw these kind of intramural blood pools in those regions in some of those areas. Sorry, it's not the easiest to see here. But anyways, just a nice case of how the evolution of these intramural blood pools from an IMH to those, and then the resolving, and then the actual IMH decreasing in size. Not the best way to show that. Sorry about that. And then this is just a case where I think we've all seen this. Just another example, patient with a Impella device and had a non-con-chest CT, which you really wouldn't say much on, and then kind of sitting in the hospital and started having some decompensation, and they got an enhanced study this time. You can nicely see the biventricular assist device here, but just as importantly, so they put in an LVAD, and when they either put in or took out the Impella or was doing something with the LVAD, you can see that there is this very large aortic thrombus now. So, you know, it's probably related to the Impella device. These aren't that uncommon to get some sort of intimal injury and subsequent thrombus from the Impella. And you can see that there's clot all along the wall of the aorta here going up. I'm sorry, the aorta femoral artery into the iliacs and then up here. And then unfortunately, as a lot of times happens with these, patient presented both with distal limb ischemia and a stroke. So it's just another complication of, again, it's not really 100% sure whether it was due to the Impella or the LVAD per se. We presume it was related to the Impella, but who knows? But just another iatrogenic aortic injury and subsequent thrombus and subsequent embolization. But all right.
Yeah, that's really interesting. So I had a case, I don't think I showed you guys, I should have, but I'll try and retrieve it. A couple of months ago, we had a request for a CTA and they didn't even give us any history. And we saw thrombus about the Impella device in the descending aorta, probably 2 to 3 inches worth. And then they said, oh yeah, when we tried to take it out, we had met some resistance. So we wanted to see what the problem was. So we diagnosed thrombus about the Impella device.
Yeah.
And then they decided to just go for it and they just pulled on it and it came out and there were no other complications. But it's almost identical to the one that you're showing, except
this one had complications, yeah. But you know, a nice juicy aortic thrombus. So Impellas are definitely good, very, very good devices, but there are complications associated with them.
All right.
All right.
Thanks. All righty. Who wants to go next?
I have plenty. I can show some now, or I can wait. Doesn't matter to me.
Okay, why don't you show some, and then if we have time, we
Okay.
can come back around.
You guys see a Rankinogram?
Yeah.
So these first two cases I'm going to show you are courtesy of my resident and future fellow, Jay Sohn, who saw these on call recently. This is a patient who came in with respiratory symptoms, just dyspnea, generalized. Had this radiograph, not the best portable, but you can see there's some retrocardiac opacity, kind of lost the left heart border here. Maybe a little bit of an effusion with this little meniscus there. The patient has some renal insufficiency, and so they did a non-contrast study to further evaluate, and you can see the presence of the effusion. It's a small effusion, and then there's some consolidation in the left lower lobe. And having seen examples before that we had, that we like to show in conferences, this area kind of looks like central ground glass, maybe a little bit of higher attenuation consolidation surrounding it, and the presence of the effusion. Jay was wondering if there could be PEs, and sure enough, looking at the main pulmonary arteries, there's some heterogeneity in here.
Ooh.
And you can see quite a bit on the right. So talk to them, turns out, of course they're worried about COVID, but the patient's not febrile and has an elevated D-dimer, and they repeat, and you can see these are huge PEs. So, and this patient was hypotensive, I think, at some point. So clinically met a definition of massive pulmonary embolism. But you can see this was in fact a nice little area of infarction in the left lower lobe. And of course, pleural effusions, sterile exudates we see in like a third of patients that have infarcts. And so this is all related to PE. And also I think it's cute that there's a little patent foramen ovale here. So you can see the contrast in the interatrial septum, and it kind of shoots up towards the left atrial roof, as we can see, typical of a nice little PFO. And you can see it well on this sagittal here as it shoots up there.
Travis, did you say it was COVID positive?
No, I said, no, that was of course their original concern, but no, he's been COVID negative. And yeah, that brings up an interesting question, with all of the recent data suggesting much higher rates of DVT and thrombus formation in COVID patients, but he was not. This was just PE on a non-contrast study, not COVID. So yeah, but this was a really good pickup here.
Yeah, you have to change the window with well. And it's not obvious that he's anemic. For example, that is the blood pool relative to myocardium.
Right.
Is not particularly anemic. So one of those cases where the clot is hyperattenuating relative to whatever blood measures. Yep. Wow.
So that was a pretty one. And then this must have been an exciting night because this one came in as well. This is a young patient, very dyspneic, or she's 58, I guess, had this CT, also a PE study. There's no pulmonary embolism, but I will show you on her lung windows that she has, at first glance, it looks like just diffuse ground glass opacity with some areas of lobular sparing. But of course, the closer you look, you see there is a relatively diffuse ground glass, but there are more discrete, but still fuzzy centrilobular ground glass nodules throughout the lungs, and some areas of lobular sparing, or perhaps even air trapping. We don't have any sort of expiratory on this since it was just done in the emergency department.
But those,
and so the question,
Travis, the relatively clear areas also have those centrilobular smudgy islands.
Yep, like just a little bit, right? Yep, the nodules going down further out. Yeah. Well, so that raises a question. Like on this image here, you could argue that you see 3 different densities. Like maybe there is some areas that would be that there would be air trapping if you did expiratory. I'm curious what you guys think about that.
I would think so.
Yeah, and those lobules look bigger than a normal lobule at that level.
Yeah. So
what was she inhaling?
Yeah, so not inhaling anything in particular, not in terms of like she's not vaping or smoking marijuana or anything, but about a year ago she did get 2 birds.
There you go.
And yeah, so, and Jay had shown this to me with the question of, is this some sort of viral infection? Is this non-infectious? And absolutely, this is typical of, I guess, what now would be more active or inflammatory hypersensitivity pneumonitis.
That's a really profound case. I mean, that's really pretty. I haven't seen a nice case like that in years. That's really impressive.
Yeah, I know. I think the last few I've seen that have been this traumatic were ones that I think Howard showed and maybe Jeff showed with different like poultry workers or whatever. But she just she's had 2 birds for a year.
She's spending more time with them.
Yeah, exactly.
And this is one.
She's living at home with them all day now. You're right. You're probably 100%.
Yeah, you're right.
You should find out if she. Yeah, that's really fascinating.
That'll be interesting.
Actually,
there's an uptick in
HP with.
Yeah, we talked about that with the Valley patients last week. Just how, like some of us drink more because we got nothing else to do. Some of us maybe vape more because we got nothing else to do. And I guess maybe she's just hanging out with her birds more because she's got nothing else to do.
Yeah. Well,
a lot of the animal shelters have emptied out because so many people have adopted animals.
Yeah.
So
cleaning out the cage once a day instead of once a week.
So the I guess one point of this is, again, we still have not seen or read any descriptions of cases of COVID with discrete nodules. Certainly not like this. This is a classic look for HP. And pulmonology was sending her home, get rid of the birds, steroids, and she did have at least one COVID PCR that was negative.
Does she have some smudgy lymph nodes in the mediastinum, Travis?
Now she's got a big azygous arch here. A few, little reactive guys. Why do you ask, David?
Well, they're not as sharp as sarcoid nodes, but there's modest smudgy lymphadenopathy here. So I wouldn't be surprised, given how much acute lung disease she has, to have some nodal component.
Sure. So, okay, Jeff, I can stop there and show a few more later if there's time.
Okay. All righty. David?
Not this week.
All right. Peter?
I have one.
All right.
Yeah, so this was a patient I got paged about on call in the middle of the night a few days ago. 50-year-old female, past medical history, hypertension and smoking, and she was working at a store during the day, I think as a cashier, and just had a sudden onset syncopal episode and altered mental status, and she went to an outside hospital the same day. And this is the CT that they got. Apparently she's also had a history of some type of dissection. They didn't have any details. History of dissection, which was treated non-medically. And then so she went to this outside hospital, they did this CT, and then she was transferred to our institution later in the evening, and I got paged by surgery. So this was a study. And they basically at the outside hospital, they'd kind of hedged. They'd mentioned something in the aorta. They weren't sure if it was thrombus or dissection. And so this is the interesting finding here. And there's also a hemopericardium, and you can see a streak of high density coming in here, going into the pericardium, right where this. So I told him this looks like an acute tear there. Specifically, I asked him if there's any trauma recent, like acute deceleration or acceleration or anything like that, and they said no trauma, no recent cannulation or other procedure there. And then I followed up the next day just to see if what happened if they operated that evening overnight, and it turns out they decided to watch him until early in the morning, but in the middle of the night the patient got sudden onset bradycardia and ST elevations, and they did a bedside echo, and on the echo they saw the dissection. This is involving the aortic arch, descending aorta, and ascending aorta. And early in the morning they operated. This is the part of the op report. So it's basically a type 1A or type 1 aortic DeBakey type 1 aortic dissection. So it turns out this was imaged right before, with the entry tear here, right before this dissection progressed to involve essentially the entire aorta, with bleeding into the pericardium. And it was interesting because at the time when they called me, they said the patient was completely asymptomatic without chest pain and stable hemodynamically, like talking, sitting up in bed at this time. And just matter of hours later, progressed to a full dissection.
Do you think there's left ventricular hypertrophy there?
Yeah, 100%. Yeah, yep. And then she had a history of hypertension.
That's a lot of hypertrophy, isn't it, for just hypertension?
At some of our hospitals, I see this pretty often, just from hypertension.
Got it.
But yeah, there's no other history. I mean, I guess it could be hypertrophic, but didn't have any history.
How old was she?
50. Smoking and hypertension were the histories.
Got it.
It seems pretty circumferential to me.
I leave it up to you guys. I'm not very good at judging that, so I'm just wondering.
Yeah, it looks circumferential. I've seen hypertension that bad.
Yeah.
Just on routine CTs.
Maybe it's a red state thing.
Yeah, no, you definitely get some people with some aren't thick hearts. I think it's probably just hypertension. I don't know, is hypertrophic cardiomyopathy, probably not associated with increased risk of dissection.
Not that I've heard. I mean, some cardiac death, obviously, but not that I've heard of.
Good dissection, yeah.
Yeah.
Unless there's a hypertensive component to it.
Maybe they had aortic stenosis.
And then I noticed.
That's a good point. Was there
Like a bicuspid aortic valve, maybe, or something like that.
Yeah, I mean, here I can see 3 cusps, yeah, but yeah, in this case. Well, that's all I got, guys.
All right. Okay, I'll show one real quickly. Let's see here. So this is, let's see, you should, guys see 2 CT scans?
Good.
All right, so this is a patient that's got a bad lung cancer, and let's see, I always forget the button. So yeah, these aren't the real dates, but anyway, you can see they're a few months apart. And what was interesting, actually, so you see this really ugly, hold on, let me make my GoToMeeting thing go out of the way here so I can see what I'm doing. But you can see there's this lung cancer that's filling quite a bit of the mediastinum, very infiltrative looking. And I'll show you, you can see the serratus anterior muscles there. It's a little thin on the right, but not well developed there. But this was the follow-up scan, and it just, to me, was so striking how the serratus, just over a few months, really atrophied a large amount. And so if you look on the follow-up, there's a lot more. The cancer got worse, and it started filling in here, where the brachial plexus would be. So the serratus anterior is innervated by the long thoracic nerve, which gets its nerve roots from C5, 6, and 7. Comes off, I think, the superior trunk of the brachial plexus. So I think the tumor got in here and caused a plexopathy, and it's the motor nerve for the serratus anterior. So I think it caused this atrophy there. There's, you can see, it's pretty good looking serratus there. It's no longer, it's thinned out quite a bit. So,
wow, that's a great observation.
Yeah, not terribly exciting, but just an important, at least when you see that, I mean, I think it's probably easier to pick up the tumor up here, but this is at the very top of the scan, so should give you a tip off when you see that asymmetry, especially in a patient who's not had thoracotomy. And you can just see how infiltrated this is too, with all these just numerous collaterals in there, just a very ugly tumor. And the SVC is this thread, but yeah, it just kind of grew up the mediastinum. So it's, I don't know, it's a non-small cell. I don't know what subtype it is, but I mean, presumably an adenocarcinoma, but a kind of a sort of atypical route of spread of lung cancer to do this, but then grow up along. So you wonder if it's growing along some nerves or something, and then goes out to the brachial plexus. And I do have the coronals. This is the new coronal. This is the old coronal. So you can see, we'll just put them up. The other thing, I think another important thing to notice is notice the patient's arm. You probably saw it better in the axils, but the arm was positioned differently. The arm is down on this one. So with the plexopathy, I'm guessing there's less ability to control that arm as well. So I mean, for the trainees out there, anytime I see an arm down on a scan, I always try to figure out why. And if you have a good technologist who puts a note in, that's very helpful. Sometimes it's because they have a bad shoulder. Sometimes they're having pain because they've broken something. So like on a, one of these ground level fall scans that, they may just do a chest CT non-contrast. That may be a clue that there's a fracture that's not in your field of view, but you can pick up on a scout, like a humeral fracture or dislocation. So I find that helpful as well. But in this case, I'm presuming it's because of the plexopathy.
Jeff, was there any involvement of phrenic nerve? Because that diaphragm seems to be higher. Was there?
It's high on both, so I'm presuming that if we go back to the axials, I mean, I'm presuming the phrenic nerve is gone. It should be in front of the bronchus, so this area in here, and then you don't see it down there, but it was up at least on both of these scans. I can't imagine it wasn't out.
Can you scroll down and let's look for atrophy of the cruise?
Oh yes, pretty thin.
It looked pretty thin over there.
Yeah, and I think it was thin on the old one too. Yeah, pretty thin there too.
It's gotten worse.
Yep, no, it's true right here compared to right there. All right, well, that's all I have. Okay. Anyone else before we circle back to Travis?
I got 1.5.
Oh, excellent. I'll make you the presenter. Let's see here. No, I did that incorrectly. Sorry.
I got it.
Oh, excellent.
All right, can you get, it looks like you guys can see my screen. So this is a 83-year-old lady who underwent a transcatheter mitral valve replacement. So most of these are, even though we say it's transcatheter, they still do a transapical approach. Here's the mitral valve apparatus. And what you can see here, this is a patch they put at the site of the ventriculotomy. You know, usually they try and do it at the apex, at the apical fin spot. For whatever reason, this one was along the apical anterior wall. Other findings on here, the PA is big, the atria are enlarged, there's a little bit of bowing from right to left, there's reflux of contrast into the IVC and hepatic veins. So a lot of these are followed with multi-phase CTA. And so when we did that, you can see this. So here's that plug that was used to seal the site, and you can see this was new from the pre-op CTA. This anterior wall is just not moving; it's kind of just stuck in place. And there's a new septal flattening, and I think maybe even a little bit of diastolic septal bounce as well. And a couple other interesting findings related to that. You can see here on the cine, just showing how that anterior wall is kind of restricted there or constricted there. Similarly on this, you can see probably a little bit of blush of relatively unapacified blood shooting from the right atrium to the left atrium. Some of that could be chronic though. The other reason I wanted to show this lady was I've had a couple of these now where it looks like they have who go for transcatheter mitral valve or are being evaluated for that, where they have severe mitral regurg and stenosis and what looks like pulmonary fibrosis. Here's the chest radiograph. Here's the lateral. Here's the lateral chest radiograph from that time. And of course we've got CTs as well. And this is the CT showing lots of thickened interlobular septae, relatively minimal traction bronchiectasis. And there's a companion case that I saw the same week, also showing lots of thickened interlobular septae. It's not a clear basilar predominance. This one maybe looked a little bit more upper lobe predominant, but not too much. So I tried doing some digging, and the most I could find, I found this old paper about mitral stenosis and pulmonary fibrosis, and which seems to suggest that you can have if you have chronic mitral heart disease, you can get pulmonary hemosiderosis, and you know, of course, these rentgenograms are a little tough to interpret. So I was wondering if you guys seen, especially anyone who's been practicing longer than me, seen like pulmonary alveolar hemosiderosis showing up as fibrotic lung like this?
Yes. Yes.
Yeah, I've seen. Oh, go ahead, David.
It was a thing that was discussed, you know, back in my training time in the 70s and stuff like that, when we had people with chronic mitral stenosis, and it probably is also what gives rise that hemosiderosis leads to fibrosis. And so what you have are permanent curly V line. They don't go away. And instead of being edema, they're actually fibrosis where there was edema before, and probably low-grade bleeding leading to the hemosiderosis. And then some of those cases would also go on and get little bone formation. So it was a cause of DPO. And it's probably all related to that scarring process that's initiated by blood. So blood causes fibrosis, causes scarring. And some of that will go on to ossification even.
I'm glad you brought that up, David, because I've seen that a lot, particularly the permanent septal lines on CT in patients with chronic heart failure. And I think you have to be careful not to overcall edema. And you can go back and same septal line on every case.
Right.
Yeah.
And yeah, you get a little ground glass. Yeah, you get ground glass with it as well, because we have those occasionally get referred to our ILD. Our multidisciplinary ILD conference, and you know, it's not something that's very well described in the literature, but you know, we see it.
Yeah, I almost wonder if some of these were calcified or ossified. Yeah, I couldn't find anything with CT findings of chronic mitral heart disease. All I could find were these old chest radiographs.
Well, the reason is that you know, people don't have we don't have very many cases of chronic mitral disease anymore. They get, they get therapy early. In the old days, they would go on and on. They were reluctant to do surgical therapy because they were reluctant to do open heart surgery initially. So it's really, it's a kind of a disease that's faded away. We just don't see the extreme mitral stenosis except in, for instance, in immigrant populations where people come from places where they get medical care early.
And older generations of pathologists are more used to seeing siderophages, iron pigment in macrophages, and the ossifications associated with chronic pulmonary venous hypertension as well.
Fascinating. Do you guys know, did these people suffer this degree of like pulmonary hemosiderosis? Do they suffer kind of the same way that someone with IPF would of a similar degree?
I doubt it, because it's more indolent, and so I don't think it's a process. But I think another interesting observation here is that with mitral disease, if there's a regurgitant component, then you get the selective right upper lung edema, and it looks to me as if we got selective right upper lung fibrosis in this person. So I wonder if that also reflects hemodynamics.
Yeah. Let's see if the other one had similar.
Have you guys seen this described similar to DIP with the hemosiderin macrophages, like the pattern?
That's kind of what it looks like, with, especially if you have a more predominant ground glass component.
Yeah, we had a big debate amongst two pathologists who were struggling to differentiate between hemosiderin-laden macrophages and kind of the smoker's macrophages in DIP. They can look nearly identical. Yeah, I've seen some primary hemosiderosis cases. So this is all secondary to mitral valve and just kind of
I think that experienced pathology,
So Brian,
experienced pathologists can tell the difference between smoker's macrophages, those macrophages containing that pigment, versus siderophages by virtue of the appearance of the pigment itself, even before you stain for iron, based on their experience.
So Brian, you seem to be bringing up these oldies. A couple weeks ago it was syphilis and stuff like that. I think it was you.
Peter.
I had this. Okay.
And that was,
but yeah. It's always good to get a different perspective. Yeah.
Well,
But it's good to bring it up because
I was going through my predecessor Mel Figley's teaching files, some of which are still hanging around, and I found some cases of crazy paving, which is when the emulsion on the film sort of buckles and forms this, looks like the skin of an alligator, or is a crocodile, which of those that the Texan people make boots out of. But so that was a case of very nice crazy paving pattern. But I also found two more cases of syphilis of the aorta. So I'm going to inflict those on you guys next week if I can get them.
Interesting word choice. No, but I think it's good to see talk about this stuff. Like this is like the edema, the chronic heart failure and fibrosis. I think we're aware of it, but you don't see it in the textbooks. You don't see it. You don't hear about it, in conferences. I think people aren't aware of it.
Yeah. The only, like I said, the only papers I could find were radiographs or path specimens.
Yeah.
Right. If you can't get it online, it's too much work.
It's interesting you bring up the macrophages, because if Jeff lets me show my screen, I had this kind of conversation online with a lung pathologist, and a colleague of his basically chimed in because we talked about DIP and non-smoking DIP, and I asked them whether they see cases of DIP in non-smokers, and we talked about the pigments. So he sent me this picture, and you can see here he was showing the difference between the appearance of the macrophages with what he labeled as smoker's pigment, much finer with a couple of specks, versus the hemosiderin laden macrophages. So those experienced pathologists can generally tell.
I also think showing this in a slide as a clear distinction. I'm telling you, I've seen some very good pathologists go back and forth
I see.
on this same topic.
Yeah.
You know, I where they really struggle. I agree. I always thought it was a very, very simple thing. And it was interesting. The two pathologists actually brought it to like one of the main pathology meetings and had like a whole, the expert panel of really, you know, also argue about it for like 20 minutes. So
Yeah. It's interesting. Yeah.
Howard, is there any overlap with the hemosiderin macrophages from the pulmonary hypertension, where you get that smudgy ground glass that's right around the center of the lobule? Is that at all related?
In pulmonary arterial hypertension?
Yes, yeah.
No, I'm not familiar with that.
Okay.
No, but you do see, I know your point. The point is, and we see a lot of PH here, especially explants, and you do see in some cases periarteriolar macrophages that are filled with hemosiderin, presumably from some areas of bleeding around the
Oh, I see.
area of the small arterioles. But you know, there's even debate that that's the cause of some of these cases. But I have to say, a lot of the cases where we have profound, you know, those hazy centralobular or hazy nodules or whatever around the vessels, that it doesn't correlate to that on path. We're just not seeing it. And similarly, I know Dave showed, you know, says cases where it associates with plexiform lesions, and we haven't seen that in the 7 or 8 cases I reviewed, but I don't know. I'm trying to get someone to do a micro CT study on it. Anyways, I digress.
All right. Well, thanks, guys, and we'll meet again next week. And everybody stay well.
All right, take care.
Bye.
Thanks, everyone. Bye, everyone.